Hi, my name is Ruta Rao. I'm a breast medical oncologist and a professor of medicine at Rush University in Chicago. And I'm joined today by my friend and colleague, Ozzy, and I'll let you introduce yourself.
Good morning, Ruta. My name is Dr. Azadeh Nasrazadani. Please call me Ozzy. I'm an assistant professor in breast medical oncology at MD Anderson and excited to be here today.
Great. So we're here today to talk about hormone receptor positive, HER2 negative metastatic breast cancer, and specifically to focus on the second line landscape. So we know that this therapeutic landscape has really changed over the last few years with the detection of mutations, the development of novel therapies, as well as using combination therapy. So it's been a really exciting time for us to be able to offer these treatments to patients. So we know that there's many things that go into treatment decision making. Do you want to talk about some of the things that you find when you're thinking about somebody in the second line that's hormone receptor positive?
Absolutely. Ruta, so many things go into that, as you can imagine. The first thing we're thinking of now in this new evolving landscape is what are the biomarkers? Namely, we're thinking of ESR1, PIK3CA, AKT, PTEN, and that really makes a difference into what tools we have in our toolbox and what we can even offer. And of course, beyond that, we're thinking of what strategically even makes the most sense. How are we going to sequence those? How much benefit are we going to get from each line? So sequencing, of course, that all goes back to what we anticipate that will be as far as the duration of response and what response we've already achieved with that first line, which I think gives us quite the insight as far as whether or not it's appropriate to be going down endocrine-directed combinations and for how long we can anticipate doing that. But amongst other things, I think those are the key things we're really looking at now with this evolving landscape.
Absolutely. So let's talk a little bit about sequencing in particular. So I think we can safely say for most of our patients, we give them endocrine therapy with a CDK4/6 inhibitor in the first line setting. So when we're getting to the second line and we're thinking about how to sequence, how do you decide if a patient's going to continue on endocrine therapy? What are some of the things you look at, patient factors, disease factors, and how do you kind of put it all together? Because we know we have a number of different options available, further line endocrine therapy, and even ADC therapy in this setting.
That's really hard because you want to think about all the different options that you have and trying to anticipate again what we think will be strategically the next best move. But things to think about are, how can we maximize each option that we have and really not close the door on those things. So I think it's easy to say in patients who we know blow through endocrine-directed combinations in the first line, that's a little bit difficult because most likely we're going to be headed into the ADC space, cytotoxic therapies a lot sooner than we had hoped. But we also know that it's unlikely that we're going to derive benefit if we ever come back to it. So it's really challenging to close the door on that unless you know that you have really given the options that you have a fair chance. But of course, we have to be realistic and think, am I going to get 3-4 endocrine, directed combinations before I can hit an ADC? For that specific patient, probably not. Whereas for the patient where we perhaps will have been on a CDK inhibitor with an aromatase inhibitor, let's say for 3-4 years, I think it's hard to immediately then go to an ADC, knowing that they very well may have now an intervenable mutation that we now have multiple options for. So I think those are more obvious cases, but there's a lot of in between. And so I think specifically for me, I think, can I at least trial something with closer monitoring, knowing that I really maximized, every line of therapy and really didn't leave anything on the table as far as our tools. I think knowing what we know now in recent years as far as the biology of these tumors, again, it's hard not to take advantage of some of these targeted therapies.
Absolutely. And I think, as you kind of mentioned, one of the things we really look at is the duration of therapy they had on their first line. And this was really shown to us even in the Emerald trial, that the patients who had more than 12 months on their first line of CDK4/6 and endocrine therapy had a longer PFS when they moved on to ESR1 directed therapy with elacestrant than the patients with a shorter first line duration. So I think that's something we've always kind of intuitively known. If patients get a longer response to their first line therapy, they tend to do better with the second line as well. But it was kind of nice to see that in clinical trial data.
Of course. But, I think that certainly doesn't mean that we won't get any response or any clinical benefit. And I think it's hard because intuitively you think, oh gosh, this patient has progressed perhaps earlier within 6 months. Are we going to, really get any, derive any clinical benefit from perhaps targeted agent for ESR1, PIK3CA, but that really may be the driving biology. And so I think while it's perhaps not as reassuring to feel like, oh, I'm going to do well with this one, I really don't think that we should be closing the door on those options either. But for sure, I think that is a better scenario.
Correct. So let's talk a little bit now about the biomarker testing that you brought up. So I think, definitely we're looking at this earlier and earlier than we used to. So do you want to tell me how you use biomarker testing in your practice? Do you test patients at diagnosis of metastatic disease? When do you repeat the testing? What type of testing do you like to do?
My attitude has actually really changed in recent years, and I think a lot of that, of course, goes back to what insurance allows us to do. So many of us are limited by that. And I used to be more strategic in when I would do what. And I always used to prioritize doing tissue testing because I thought that was more reflective of the overall picture. However, we're seeing from specifically like ESR1 testing or even PIK3CA the likelihood of detecting it in a liquid biopsy, and you really don't want to miss that. And so in recent years especially, knowing that it does make a difference what options I have, I am being more aggressive. I am certainly getting both a liquid biopsy, both tissue testing at diagnosis. I didn't always used to do that, but I think we have absolutely more of a reason to do that. And of course, getting at least at minimum a liquid biopsy, if possible, at every progression, to the extent that we're able with our confines of insurance, but because it can really make a difference in what you can offer that patient and how much you can delay time to chemotherapy, time to an ADC. That can make a really big difference in outcomes. And while we don't have that data, I think it's something that intuitively makes sense to do.
I agree with you. And I think it's when you do it at diagnosis, it's also nice to know some of these mutations like the PIK3CA and the AKT pathway mutations are truncal mutations. So if you know that a patient's tumor has them, it's sometimes nice in your own mind to plan like what might be my second line of therapy and just kind of lay out your roadmap for these patients.
Absolutely. It's as you know, when progression happens, you want to make sure that you know what the plan is, and having to wait for, biomarker testing, inevitably taking a few weeks, not only, confers more anxiety to the patient, but you also want to make sure you hit the ground running. So absolutely, I think it's helpful to plan in advance. It gives that extra reassurance to patients, just to kind of know, what's next.
So we know for patients with HR positive, HER2 negative metastatic breast cancer who have a PI3 kinase mutation, that these patients tend to respond to targeted therapies. So tell me, when you're thinking about that, where you put that line of therapy. We know now that there's a targeted agent we can even use in the first line. Is this something you wait for the second line, and how are you kind of figuring that out?
Such an important question, and such a imperative thing for us to answer, and something that we don't have data for. I think that in different pockets we have data for things. So for example, like we know we have inavolisib, but that is such a narrow pocket of time. And I think when the ad approval first came in, I thought, this is going to be great. I'm going to give this all the time. But truthfully, it's more narrow than I would have thought. I will say, because of where it pops up in the NCCN guidelines, I see that being recommended a lot in community practice specifically, but I think it's not as clear as it should be that really has a pretty narrow indication of where to do that. So I can't say that I'm necessarily doing that in the first line outside of that very narrow specification, because outside of clinical trials where, yes, that may be an option, I very much am saving it for kind of the second line. But I think it's a little bit tricky as you think about not only the role of PARP inhibitors, and that makes it a little bit more challenging. But I think the kind of perhaps the elephant in the room is ESR1 first or PIK3CA first. And inevitably, I think that's something that we all kind of think of, and we get there when we get there. When I think about it, I think part of it is, I think of the timing of when I anticipate finding that mutation. As we all know, and we've seen, ESR1 mutations more likely to happen in later lines, after evolving after, a few lines of therapy perhaps. Whereas it's comparatively more likely that you're going to see a PIK3CA mutation, PTEN, AKT up front. So whether or not, the biology of that, that makes a difference to hit it then, I think that probably plays more of a role in the inherent biology and in what's driving the bus here is, the expression I like to use a lot. So whether correct or not, and the data one day will be revealed to us, I prioritize PIK3CA pathway targeted agents over ESR1 for that reason, although I can't say I have the data to support it. But with the tools that we have and just how they're each individually studied, that's at least my personal preference.
Yeah, and I think you brought up a really important point that I just want to emphasize, that we do have the ability to use PI3 kinase targeted therapies in the first line, but that indication is very narrow. So I agree. I was very excited, and I still think it's great data from that trial, but it's very few patients who actually meet the trial criteria with that early recurrence.
Yes. So Ruta, what do you do? How do you sequence when it comes to the ESR1 and PIK3CA?
Yeah, I agree with you. It's a challenging, the nice thing is that we know that those patients have multiple targeted therapies available. So I think some of it is talking to the patient and telling them what are the targeted treatments available, what are the side effects of each treatment. But I think a lot of it also has to do with their disease progression, their disease burden, what other side effects they have. Sometimes it's a older, more fragile patient, and I don't want to rule out patients based on age, but certainly you take into their comorbidities and their fragility, and they might not be able to tolerate the PI3 kinase targeted drugs. But then I've also found that some of them have a lot of side effect with ESR1 targeted therapy, especially the nausea. So I think it does get tricky.
Another thing I worry about is I wonder if I can realistically get through all of my tools in my toolbox before getting to an ADC, and what do I want to make sure that I definitely get, kind of sneak in there. And I think that's hard because you don't know which one is going to be better. They haven't been studied head to head. But at the same time, if you see someone, perhaps to your point with the burden of disease, if you have now suddenly liver mets or the burden of disease is such that you think, I can trial one thing probably. How do you choose that one thing? And I don't know that we have the data for that, but I agree with you that I think that does come down to what may be reasonably better for their quality of life, what they can tolerate. Perhaps, I think admittedly with PIK3CA targeted agents, hyperglycemia, is that something that's prohibitive? So sometimes that can guide us, but I do think that sometimes it's challenging not only sequencing, but if we realistically know we're not going to get in multiple lines, which one can we choose?
Yeah, I think that's a great point. We have all these therapies, but do we have time to get them in?
Yes.
Yeah. So let's talk a little bit specifically about the PIK3CA altered population. Do you want to just give a brief summary of the data that we have for these patients with targeted therapies in the second line or later? I know we have two drugs available, alpelisib, Capivasertib. How do you think about these drugs, the efficacy, the trials that led to their FDA approval?
So in broad strokes, I know that we have two main agents. There's alpelisib from the SOLAR-1 clinical trial, and of course we have Capivasertib, the newer kid on the block from the Capitello studies. I think we all admittedly struggled with alpelisib, specifically with the hyperglycemia aspect of things. I think the quality of life was surprisingly, a bigger difference than we were anticipating. With Capivasertib, I will say that it has been significantly better, and so I think that's been a lot more promising. And I think one major drawback that I think was kind of a punch to the gut was the overall survival that didn't pan out with alpelisib specifically. But with Capivasertib, of course, that is yet to be determined. However, I do think that we're seeing good clinical efficacy. It's really well tolerated, relatively speaking, and of course, we're in the grand scheme of things. And even beyond that, there are other agents down the pipeline. So I think there's multiple things to consider as far as, again, how our culture will evolve as far as our comfort and where we will inevitably find the right patient, and how as a community we will decide this makes sense to sequence in what way. And if our data does evolve such that we do have options, agents that perhaps may be coming in the first line, how will that change things? But I do think in the grand landscape of things, our really big players right now are Capivasertib and alpelisib.
Yeah, I think that's great. And I think it's really important to remember that the one of the differences between the two is that Capi is indicated for patients who not only have the PIK3CA mutation, but also the AKT and PTEN mutations. So if you look at that, that's almost about half of our ER-positive, HER2-negative metastatic breast cancer patients.
That is such a good point. And I was actually thinking about that earlier, because if you think about, for example, the patient who may have received inavolisib, does that mean they can't get Capivasertib? And I think that's pretty hard. Again, I think it'll come down to, at that specific time, what is the burden of disease? How much mileage are we getting? Do they have a nice duration response to the subsequent therapy? And is that the one that you're going to prioritize? Versus if they also happen to have an ESR1 mutation that you can intervene on. But again, to that very point, I think that you can't necessarily say, if they have an AKT mutation as well, does that mean they can't be a candidate to, again, retrial that type of an agent?
Mm-hmm. That's a great point. One of the other things that kind of sticks out to me, and a lot of it has to do with when these trials were designed and what patients enrolled on them, but the Capitello trial really is more relevant to today's patient population because one of their trial entry criteria was that 51% of the patients or more had to have prior CDK4/6 inhibitors. And as we started with this, we know that almost all of our patients get CDK4/6 in the first line setting. So I think the Capitello trial had, 60% or more patients who had prior CDK4/6 inhibitors. So for me, that's again just kind of bringing it more relevant to the patient that I see today.
To add on to that point, I know as far as culture-wise, things that we do differently, there was a time that we were doing fulvestrant and palbociclib in the first line before getting an aromatase inhibitor for de novo patients. And again, this is based on the strength of the data, how excited we were, and now knowing what we know, many times now we'll be saving the fulvestrant perhaps for, I know at least like in our institution, to combine that with the clinical trial, a more novel agent, or just to save it for capivasertib. Both SOLAR-1, both Capitello, both of those studied respectively those agents with fulvestrant, with the idea that they were fulvestrant naive. But again, our attitudes have changed, what we know has changed, and all the little nuances of things that we're doing differently. So it's really hard to compare population to population, but as we're getting kind of smarter about it, I think we're learning more as well along the way.
Absolutely. Absolutely. So we talked a little bit about the appropriate patients, and we talked about their prior duration of response to their first line therapy. We talked about disease burden, but what about some of the comorbidities of these patients? So when you're thinking about these patients and whether they're candidates for capivasertib or a PI3 kinase targeted drug, what are some of the considerations you take?
I know many people in the community have hesitations about the hyperglycemia, and certainly a lot of second opinions I see, our patients will say, I was told I can't have drug X, so I cannot have alpelisib, capivasertib. And I think that's hard, and perhaps maybe I'm more on the aggressive line of it. Maybe I'm more on the aggressive side of things. But again, it's really hard for me to not utilize the tools that I have before really exhausting that if I know that I could potentially get good benefit, especially for that patient who had 2, 3 reasonable good time on a CDK inhibitor to close the door and say, oh, you have diabetes, or oh, your A1C is high. I mean, certainly some things are, more obvious than not, like perhaps A1C over 10 is not the best candidate. But I think short of that, I think we should have some wiggle room. All of the pharmaceutical companies have such, comprehensive manufacturer recommendations for monitoring, dose reduction between up to date, all the different tools at our hands. We have the tools, and even in the community, I think we have good access to them. So I do think we owe it to our patients to really trial things within the safety parameters that we have and not close the door on that. But outside of that, honestly, I think they really are the targeted therapies, whether it be ESR1 targeted therapies, PTEN, AKT, PIK3CA targeted therapies, they really are better tolerated, especially the more fragile patients. And, let's say like sacituzumab, right, or HER2, even the ADCs, which really are comparatively better than harsh chemotherapy, they're not always that easy for patients that we think it's going to be a home run. So for me, I really do try to exhaust those options. And as far as what I think of the right patient and the comorbidities, there is very little that I would say should hold us back on really being open-minded to these targeted therapies. It really does come down to precision biology, really trying to be strategic about what is driving the bus, what is driving progression. That could potentially make a very big difference in their overall survival. And I think we need to be more open-minded to how do we work around the confines of what comorbidities there may be.
Yeah. And I think you're right. Hyperglycemia is one of those that we're always worried about. What's their hemoglobin A1C? We know the Capitello trial had a little bit more of a liberal inclusion criteria. I think their hemoglobin A1C could be all the way up to 8. But I want to circle back to something you said earlier, talking about finding these mutations when the patients are first diagnosed. I think when we put them on first-line therapy, if they happen to have a PI3 kinase pathway mutation, and we know that this might be a second-line therapy, it also gives us some time in those patients who have diabetes to start talking to them about getting good glycemic control, so that when we're really at the point where we have to make a decision about this drug, that's not going to stand in our way.
That's such a good thought. And I mean, it's motivating as well. It gives them good incentive. I mean, for patients who have diabetes, it's probably not been like a today, yesterday struggle, but knowing that they could delay chemotherapy or delay an IV therapy, I think that may just, be the incentive that they may need. So I think that that's very clever and a very important point to have made.
Great. So I think this brings us really nicely to the point of talking about the toxicity and the side effects of these drugs, specifically Capivasertib. So we know that diarrhea, rash, and hyperglycemia are the three most common side effects. Since we've been talking about hyperglycemia, let's kind of stay on that topic. What is your approach to this? How are you following these patients when you start them on Capi? How do you use your team to monitor these patient sugars? It's a lot of lab monitoring in the beginning, especially for those patients, who have a little bit of higher hemoglobin A1C.
It is a lot of, it's a little more involved, I think, than what we're classically, having gotten used to, even with abemaciclib, perhaps every 2 weeks and then monthly, and, what we're doing. But I think it's very clearly laid out as far as the Capivasertib, the manufacturer kind of the recommendations as far as the home testing, having them kind of self-report. I know that our institution, many institutions have like a by chart they can kind of report to us. Our pharmacists are incredibly helpful in helping us keep an eye on that, but really just making sure that there's, in the beginning at least, close follow-up. And I will say, as and more involved the hyperglycemia testing is, the idea that they have this dosing frequency where they have like 4 days on, 3 days off, that really gives them a nice break every week. Versus think about how many of our patients ask for, can we delay, this cycle by a week, or this IV treatment by a week for milestone events, right? Graduations, vacations, things like that. This really does give them that extra flexibility every week, if you think about it, to kind of have something to look forward to at the end of the week. Not to say that it's intolerable, but perhaps, patients notice when they're on a medication versus when they're not on it. And I think while, yes, it's more monitoring as far as keeping an eye on making sure that you trust that patient, we'll do a good job of self-reporting, making sure they understand the schedule. I do think they have an incentive to do so.
I agree. And I've found that like a multidisciplinary approach, including, as you mentioned, our breast oncology pharmacists and our nurses, our APPs, is really important in educating the patient about all of these side effects, but then also in monitoring their blood sugars.
The education is very helpful.
Yeah. Are you comfortable starting metformin if needed for these patients? Or has it not really come to that for yours?
I am, but I do think because of all the things that we are supervising, or all the things that are kind of on our plate when it comes to goals of care, toxicities, next lines, next generation sequencing, biomarker testing, I try not to take that on if I can get away with it, just because it's an important responsibility. It really is. So we're at a place where we thankfully have really good support as far as our endocrinology team. Again, our pharmacists may be helpful, but I try to the best of my abilities, delegate that, just mostly for safety. I think there's enough that we should be focusing on as far as thinking of like the cancer-directed therapy, that makes it more doable.
I 100% agree with you on that one. So let's talk about diarrhea. What do you tell your patients about diarrhea? What do you tell them about diarrhea prophylaxis, how to manage the diarrhea if they get it? I think this is another place where education is really important, telling the patients to contact us with any signs so we can help them before they end up dehydrated.
The diarrhea, I think the patients have, fortunately or not, become a lot more savvier in how to treat it, because think about the proportion now that we have specifically patients who have been on abemaciclib. Between that and how constipating our antiemetics are, it's not to say that it's not as much of a problem, but somehow by the time they get to second line, they're a lot savvier in how to manage it. So not to say that we don't have any education or talk about it, but I do think that already having some experience with specifically abemaciclib, how they've been managing that, they know to be proactive. They know not to let it get particularly bad, or how to utilize between over-the-counter, Imodium, Lamodal, how to kind of maximize those therapies. But I think, again, because it's the second line, for better or worse, our patients are they're smarter in how to handle that.
And just to add to that, I think we, as their oncologists, feel more comfortable with diarrhea now that we've had significant exposure to managing patients on abemaciclib, sacituzumab, all these other drugs that maybe 10 years ago we didn't have that much diarrhea with our breast cancer treatments. Now we also have learned a lot about how to manage diarrhea.
Definitely. I think I recall, at least myself, how much more nervous I was about abemaciclib, neratinib. And now, to your point, my level of comfort is a lot more. It's not that I don't think it's an issue for our patients, but I do see that I think we need to give them more credit.
Yeah. And I think we just need to educate them that diarrhea is actually very common with this drug, but most of the times it's low grade, and they really just need to be on top of it. They need to start that Imodium as soon as they have their first loose stool. They need to, continue their oral hydration. They might even need to follow a really bland diet, avoid high lactose foods, avoid alcohol, all of these things that may not be that fun for them, but, can really help them in managing their diarrhea.
Agreed. And one thing that I recently stumbled on is multiple of the pharmaceutical websites. They do have actually pretty good patient-centered education for diarrhea specifically that I thought, wow, that's pretty comprehensive. So, I do think all the promotional little things help. Not to say that we have to have it, but for it to be there for the patient to be available, for it to be available to them.
Yeah. And what about rash? In your clinical experience using Capivasertib, have you seen rash? Do you prophylax for rash, or do you treat it once patients get it?
I don't really prophylax. I don't know what would be the optimal thing to do. But I think it's also one of those things that we've become somewhat more comfortable with as far as not doing anything too extreme. But I will say that it's something that I've not found to be really prohibitive beyond how we treat other things.
Yeah, I agree. I've had, a couple of patients get significant rashes, but with holding the dose, then giving them some non-sedating antihistamines, some topical steroids, and then we were able to restart it, and the patient could really tolerate it well. So
agreed. And I think in the grand scope of things, and we think about the level of fatigue, I think is more prohibitive for not specifically, the endocrine-directed combinations, but in general, I think rash is a lot more doable.
So that was a really nice review of the side effects that patients get. So let's talk about real world experience for these patients. What has made you more comfortable with these drugs? I think, sometimes the first time we see a clinical trial presented and we see these rates of 70% diarrhea, 38% rash, hyperglycemia, we're like, wow, this is going to be a lot. But then sometimes you have to try the drug, see how your patients actually tolerate it in a real world setting. So can you give us some of your real world experience with this drug?
I think definitely. And even with that, when you really look at the nitty gritty of it, the grade 1, grade 2 toxicities are significantly more than, it's very rare now to see grade 3 toxicities, especially compared to older trials. Again, not to name names, but with either one of these trials, they all do have more favorable side effect profiles. And I think that alone has given us the comfort. And, to your point, we're more comfortable with managing diarrhea. We know what to do about it. So I think when the data is there, the motivation is there. And knowing that it is delaying time to more toxic therapies inevitably, time that the flexibility that it gives them, especially for patients who come from remote places. Not everyone is in a metropolitan area. For patients who are in rural areas, being able to be on an oral option really does make the difference for them. It is not feasible for many patients to come weekly or once every 3 weeks, but for once you get on a good dosing system, if you can have them come every 3 months, for example, that really makes the difference between them treating this as a chronic illness versus this being something that they consider terminal.
Absolutely. I think that's a great point. So I know at MD Anderson you get lots of second opinions. So if you are seeing a patient who's a perfect candidate for this, and then they're going back to their local oncologist a couple hours away, and you call that oncologist and they say to you, I've never used this drug before, how are you going to make them feel more comfortable about starting this?
I think it's always been a good collegial discussion, and there has not really been a lot of pushback, but usually the conversation is, I haven't done this, but let's do it together.
Great.
And I think knowing that, it's a larger team, having someone to communicate with makes all the difference. And even in truth, our representatives, I myself am really quick to call and say, oh, what do I do with this unique scenario for this patient? But knowing that we have the resources, I do think gives me at least that confidence. And I know there's one physician I talked to who had not started inavolisib and said, but let's do it. And that patient ended up having actually quite the nice response on it, thankfully. But I agreed. I think a lot of it goes back to what we're used to doing. And I think we just have to be more open-minded to the data.
Yeah, so I think having that support is probably, especially when you're doing it on your first patient, is really nice.
I completely agree.
So just to conclude, if you had to summarize where Capivasertib and this class of PI3 kinase AKT PTEN drugs fits into our treatment landscape today, what would you say?
I think, again, it goes back to what are the tools in our toolbox? Where is this patient coming from with regard to what line of therapy? Is it a patient who has, is it de novo? Is it someone who's progressed? And it's not an easy this, then that. But I do think in an overarching way, we do have to constantly be thinking about the biology of it. Is this something that could potentially be making the difference of causing that progression? If they are not a candidate for the narrow indication we talked about for inavolisib trio, then considering the fact that ESR1 mutations may develop later, how much of a role that's playing, I prioritize that. Of course, you have to, again, keep that in the landscape of PARP inhibitors and the overarching clinical picture. But generally speaking, I think that we've come a long way. I know hyperglycemia is something that feels prohibitive, but truthfully, at least as each of us have more patients and really do see these agents in practice, I think that it's a lot more doable than we initially thought. And so that's my big takeaway message that I would say, if I've learned anything over the years, it's that that we should be more open-minded and it's a lot more doable. And it really is all about the precision medicine of what is unique to each patient and how can we be more strategic about giving them the best line at the right time.
I agree. I think, in this second line hormone receptor positive, HER2 negative setting, we're really now looking at biomarkers to pick our next line of therapy. And we have these drugs which have some unique side effects than what we're used to. I think it's on us to really become familiar with them. But specifically with Capivasertib, I found that the hyperglycemia is less of an issue than I think we were worried about. I think maybe because it targets at a different place, it doesn't cause quite as much hyperglycemia. The hemoglobin A1C
Yes.
Was a little bit more liberal. So as I've started to use it, I've become even more comfortable with it.
And it goes back to what we've seen, what we're used to, right? So I think, for better or worse, with alpelisib, it was hard for many patients. Mm-hmm. And so I think that does influence our thoughts. But I think that certainly, or even like neratinib, I know that our earlier way of giving it does influence many people in the community's willingness to give that. But again, as we learn more, as we get better at diarrhea management, the things that actually are not prohibitive, I think that allows us to be more open to the tools in our toolbox.
Yeah. Well, thank you. Thank you for your insight. I think it's, just a really exciting space to be in, this second line space. We have so many novel drugs coming out, novel combinations, and I think there's a lot to look forward to.
I agree, Ruta. Thanks for the conversation today.
Absolutely.